So we know what the problem is. The problem is that you've had an abrupt cutoff of blood flow. And so we know how to treat that. We've got to restore the blood flow. We can do that with drugs, or we can do it mechanically. But there are some other things that we need to do while we're preparing to do that. And that is supply oxygen to increase the oxygen supply. We need to slow the heart rate so that we prolong diastole, because as we know, forward blood flow in the coronaries happens during diastole. So when you slow the heart rate, you're prolonging that myocardial perfusion time. Also, the catecholamines, epinephrine, norepinephrine, can actually stimulate arrhythmias. So we block those with beta blockers that also slow the heart down. Nitrates actually reduce preload coming back to the heart, and that reduces wall tension, which can reduce ischemia. And all these things we're doing simultaneously while we are preparing to reperfuse the occluded coronary artery. We always have these patients on statins, beta blockers, and nitrates, as well as these other medications that we've discussed. Now, when do we perform a cardiac catheterization? If the patient's having an ST segment elevation myocardial infarction, they always will have a cardiac catheterization unless there is a major contraindication or it's not available. But how about the patient with unstable angina or non-ST segment elevation myocardial infarction? If their pain persists despite the medicines that we've tried, that means the myocardium is at risk, and those patients then need to go to the cath lab to have their coronaries imaged and hopefully mechanically open. There will be some very low-risk patients, or in patients who are in a low-resource environment where there is no cath lab, who can be managed with medication. But if the patient has some high-risk markers, such as congestive heart failure on exam, or a large territory at risk on EKG, we really need to open the artery in order to improve that patient's outcome. Coronary angiography is done by taking a tube or the catheter and advancing it from a peripheral artery to the heart. Most cardiologists were trained to do this by puncturing the femoral artery in the groin. Here at my institution, we have been doing this through the radial artery in the wrist for some time now. That is a safer way to do it. And actually in your heart attack patients, there is a lower risk of death when the heart cath is done from the wrist rather than from the femoral artery. Europe tends to be ahead of the United States in doing it from the wrist rather than the groin, and so does Canada. But in the US, we are doing more and more transradial cardiac catheterization procedures.